Welcome to the Baptist Health Doc to Doc podcast, a conversation for physicians by physicians, providing insight on the latest in medical practice, research, technology, and innovation in healthcare. Join Baptist Health experts as they offer practical advice for clinicians covering a wide range of specialties. Cancer, neuroscience, orthopedics, and cardiovascular care are just some of the timely discussions you'll find right here on the Doc to Doc podcast.
Hello, I'm Dr. Jonathan Fialkow, a cardiologist at Miami Cardiac and Vascular Institute and Chief Population Health Officer for Baptist Health. I have extensive experience in cardiac prevention, including nutrition and exercise management, as well as lipid and metabolic disorders, hypertension, coronary artery disease, and congestive heart failure.
Hi, everyone. My name is Dr. Dapo Iluyomade. I'm a preventive cardiologist at Miami Cardiac and Vascular Institute, specializing in clinical lipidology, cardiovascular risk reduction, and cardiovascular imaging.
Hello, everyone. I'm Sergiu Darabant, a medical cardiologist at Miami Cardiac and Vascular Institute. I specialize in the prevention, diagnosis, and treatment of coronary artery disease, valvular heart disease, arrhythmias, and cardiomyopathies.
Recently, evidence looking at the therapeutic targets in pericarditis, such as various interleukins and NALP3 inflammasome blockade, as well as clinical efficacy established in gout and arthritis, suggests a pathway to explain the therapeutic benefits of colchicine. Colchicine has been shown to reduce various inflammatory markers, and a recent study supported the clinical benefits of colchicine in patients with cardiac disease through coronary plaque stabilization, coronary artery healing after plaque rupture and damage, and overall reduction in acute coronary syndrome recurrence. Colchicine is emerging as a valuable, safe, and cost-effective therapy, in addition to standard of care for the prevention of atherosclerotic events in CAD. Let's start the conversation with Dr. Iluyomade. So, Dapo, what are some of the common uses for colchicine now? What has your experience and our medical community's experience been with this medication over the past decades?
So, thank you, John. Colchicine has been a drug that's been out for a number of decades. It was first approved in 1961 by the FDA for the treatment of gout, and 60 years later has now been approved for the prevention of cardiovascular events. Currently, it's being used for the treatment of gout. It's also being used for the treatment of pericarditis. And there are also multiple other uses, including most recently the prevention of postoperative atrial fibrillation in cardiac surgery patients, as well as for arthritic conditions in the rheumatology world.
So, Sergio, why would this medication that's been around 60 years for a bunch of conditions, most of which, as Dapo elaborated on, are not regarding our cardiovascular system, what's a mechanism where all of a sudden this medication might have a benefit in our cardiovascular patients? What's the underlying commonality with these other medical conditions that Dapo mentioned?
Well, actually, an interesting fact, John, colchicine has been used so far beyond our knowledge, even by the Greeks and Egyptians. It's actually extracted from this plant called the autumn crocus, and the Greeks and Egyptians used to use it to decrease inflammation as well, which I find that terribly interesting. But of course, it's been studied extensively more recently in how it may benefit cardiovascular patients and how it may reduce atherosclerotic plaque inflammation. It seems that there is a heavy inflammatory burden within the atherosclerotic plaque. And as the plaque becomes more unstable, it gets loaded with these foam cell macrophages, which play a huge role in the plaque formation and rupture led by inflammation.
It is fascinating how many of the medications that we use commonly today have been well known for hundreds and even thousands of years, as you mentioned. Following up on this inflammation concept, something going on in our coronary arteries, similar to processes elsewhere in the body, and now, again, a medication which might work directly against that. Why, back to you, Dapo, why is this word inflammation such a buzzword now? What have we discovered, or what did we not know that places this inflammation concept so forward in our understanding of cardiovascular disease progression, and specifically around coronary artery disease and the risks of heart attacks?
Yeah, so it really starts from the earliest cardiovascular disease studies where scientists looked at pathology slides and saw that there were a multitude of inflammatory cells along the vessel wall, especially in areas of severe atherosclerosis, or actually in the vessels of patients who had coronary events. And since then, we've been looking at possible ways to mediate that inflammatory response, to control it, to treat it. And over the years, there have been multiple agents targeting interleukins. Most famously, canakinumab, anakinra. They've had mixed results. They're not. They don't have the best safety profiles, and they reduce cardiovascular events modestly compared to the increase in adverse events. So inflammation, we know that inflammation from, as Sergio described, from the foam cell, even before the foam cell, when the endothelium is exposed to high cholesterol, when it's exposed to hyperglycemia, when it's exposed to all these conditions, smoking, tobacco smoke, you have an increase in inflammatory markers. You end up with foam cells. The macrophages then ingest those foam cells. This leads to fatty streaks, which we see as early as in adolescence, 11, 12-year-olds, fatty streaks, and that ultimately leads to frank atherosclerosis. So inflammation is involved in every single one of those steps, and that's why it's been an important target for scientists over the years.
Yeah, and as you note, with this understanding of inflammation as a root cause and a driver of cardiovascular disease and coronary artery disease in specifics, we think, why didn't we think of this before? But there has been work going on over years, if not decades, looking at the inflammatory aspect and targets to treatment, as you note. Sergio, anything you want to add to Dapo's comments?
Yes, I'd like to add to that point in mentioning that there was a very important trial in 2017 called the CANTOS trial, which studied anti-inflammatory therapy with a drug canakinumab and its effect on atherosclerotic disease. The thought was that reducing inflammation without affecting lipid levels may in fact reduce the risk of cardiovascular disease. And it was shown in this trial that studied approximately 10,000 patients with a previous MI, and these patients also had to have a high sensitivity C-reactive protein level greater than 2 milligrams per liter, that reducing inflammation at 48 months led to a significantly lower rate of recurrent cardiovascular events, up to 15 to 17% reduction depending on the dose. And this was targeting inflammation specifically.
So, as you've mentioned, I mentioned in some of the introductory comments, Dapo mentioned in his response to one of the questions, we talk about these inflammatory biomarkers. Sergio, go into that a little bit more. What is a biomarker? Why do we use them, and how do we use them? And also, how do we have to be careful to make sure that we don't treat the biomarker, but the underlying, we'll say, medical condition that drives the biomarker to be abnormal?
Great question, John. So, pertaining to atherosclerosis, in our field, we rely heavily on high sensitivity C-reactive protein as a biomarker that represents inflammation within the body. It is an acute phase protein. I'm going to
throw for a second and say there are others, but that one's we have a long history with it, and it's relatively inexpensive.
Correct. This has been studied more, but yes, there are others in preventive medicine that we look at. The reason I mentioned this one specifically is also in the use of colchicine, the guidelines rely heavily on it as well. So this acute phase protein is produced by hepatocytes, and it's influenced by cytokines like interleukin-6. And these levels for high sensitivity CRP, if persistently elevated, as mentioned, are a marker for inflammation. And pertaining to this talk, we worry about inflammation and its role in atherosclerotic plaque formation. Therefore, monitoring these markers may be beneficial for our cardiovascular patients, with the caveat being that it can also be affected by acute illness and other conditions. So while monitoring these levels, we should get a few baseline levels to make sure that they are chronically high and not just acutely high due to other conditions.
And as you mentioned, we're concerned about a chronic elevation in the CRP, so people shouldn't be checking it every 2 weeks. If it's up, it does not necessarily mean it's an indicator of specifically coronary risk. There are many other reasons for it. It's just one weapon we use to assess someone's ultimate potential risk and potential benefit with, let's say, a treatment with colchicine. So Dapo, to that point, when we talk about using this simple, cheap biomarker as others get developed and may become more ubiquitous, why do we have such a preponderance now of, we'll say, patients who are eligible for this? I mean, we talked about colchicine being developed 60 years ago. 30 years ago, we didn't even have this kind of incredible need for, let's say, colchicine for coronary disease or this inflammatory issue. What are you aware of, and what's the medical community seen that's changed over the last few decades regarding the underlying risks of cardiac disease?
Yeah, so what we've seen over the years is that cardiovascular disease remains the number one killer of both men and women globally. The risk factors for cardiovascular disease are increasing dramatically in our country and around the world. Mainly, we're seeing increasing levels of diabetes and obesity amongst the adult population and the now adolescent population. Although we've kicked the habit of tobacco smoke in this country and those numbers have come down, diabetes has gone up. And this has increased or kept the rate of cardiovascular disease elevated. One thing we're trying to do, and you mentioned, 60 years ago, colchicine was first FDA approved. Statins came out shortly after that, and we've been able to prevent cardiovascular disease progression pretty well with statin therapy. But ultimately, what we're trying to do is identify what that residual risk is for each patient and how can we get that risk down. So colchicine is really for residual risk on optimally treated patients. So all of these patients in these trials, 99% in the COCA trial and 95% in LODOCO 2 trial, were on statin therapy. And so they still have a residual risk that colchicine was able to reduce by 20 to 30%. And, that's what makes this super important in our world, especially in preventing people from having that second event, and even more importantly, that first event.
It's fascinating. Again, I'm a little older than you guys when you see the trends, but you guys are, experts in your field, that we do have these incredible weapons. Statins are incredibly effective to decrease cardiac events in the right populations. But working against these new weapons is the fact that we are more inflamed, more obese, more diabetic. So, we need to stay on top of the numbers, if you will, to affect decreasing cardiovascular events. So on one hand, we're increasing patients with cardiovascular event risk as we develop treatments to decrease the overall. It's we're kind of chasing a moving target as we go forward in a lot of ways, right? Sergio, let's talk specifically about colchicine itself. Since Dapo did mention, the personalized approach that we would take. We don't want people coming in demanding colchicine. How are you and how are we approaching presently, and where do you think it's going regarding an assessment if someone's a candidate for colchicine? And similarly, what are the caveats that the listeners should know if they're going to consider prescribing it or sending people to get colchicine therapy?
Sure, John. So in June 2023, the U.S. Food and Drug Administration approved the use of low-dose colchicine to reduce the risk of MI, stroke, and coronary revascularization and cardiovascular death in patients that already have an established a diagnosis of atherosclerotic disease and also have multiple risk factors for cardiovascular disease. The previous studies done on colchicine, one landmark trial mentioned by Dr. Dapo, the LODOCO 2 trial, low-dose colchicine versus placebo, was and in patients with chronic coronary disease, looked at patients already with that diagnosis of coronary disease and found this medication or the addition of this medication on top of already approved guideline therapy beneficial with a significant risk reduction. So in my practice, and as the European guidelines have suggested more recently, we should consider the addition of low-dose colchicine in patients that have already been optimized on all traditional therapies that continue to have a high risk of coronary artery events or even stroke, as it's being studied, and may benefit from that last line defense against further risk. It's not a benign drug. It is metabolized in the liver and cleared in the bile and kidneys. So we do have to be cautious with patients both with liver disease and renal dysfunction. And side effects when taking this medication chronically can include nausea and stomach upset, which typically actually resolves within the first few days or weeks of taking the medication. And we do always have to consider other therapies that our patients are on because we want to avoid concomitant use with medications that are strong CYP3A4 inhibitors, which could cause a overaccumulation of colchicine in the body.
I'm going to ask both of you this question, but I'll ask Dapo the question first. The trials done that we reported on and are getting a lot of both press and assessment of our guidelines were done with a particular formulation of colchicine, which is not what's commonly used for the medical conditions that we have experience with. Let me ask you if you feel, and really it's how you feel, if that is important, or would this be a class effect across any form of colchicine? Specifically, we're talking about trials done with a branded form that might be more expensive versus a cheaper form that's generic. So, Dapo, let me ask you first what your personal opinion is regarding the appropriateness to translate what was studied versus what might be more readily available and cheaper.
Yeah, this is a very important point, especially because the FDA followed suit with some of the other international organizations in recommending the 0.5 milligram dose of colchicine, whereas what is generic,
which is the branded form,
which is the branded colchicine, exactly. Right. And what is generic in the United States and used widely is a 0.6 milligram dose. Now, this is important because whenever you're trying to translate research into clinical practice, you want to get as close to replicating those conditions as possible, because that's what your practice is supported by. Now, I've done a little digging into the 0.6 versus 0.5 dose, and the benefit is similar in terms of class effect. Now, the one population where there is, we should be a little bit mindful about prescribing the 0.6 doses in those with mild or moderate renal impairment. And the 0.5 dose seems to be the sweet spot for those with renal impairment where they don't get super therapeutic levels of the drug. And so the pharmacokinetics just work better at 0.5 than 0.6 for those with kidney disease. Otherwise, if someone has normal kidney function, I would be happy to prescribe them 0.6 milligrams daily. I think that, the cost effectiveness, the benefit that they'll get just makes sense.
And Sergio, what's your thoughts regarding where we stand now? And again, I none of us can quote evidence to compare, so it's really just our interpretations of how the science supports the decisions.
Sure, John. I think the guidelines in the United States have a little catching up to do. I previously mentioned that the 2021 ESC guidelines adopted this recommendation, and I quote, per the ESC guidelines, low-dose colchicine 0.5 milligrams may be considered in secondary prevention of cardiovascular disease, particularly if other risk factors are insufficiently controlled or if cardiovascular events continue to occur. We don't have such clear guidance in our guidelines yet, in our preventive guidelines. So I think there needs to be an update there. And furthermore, this specific dose, as I currently understand, is not available as of yet in the United States. This drug is produced in Germany. I believe it is available in Europe, but although FDA approved, I'm not sure how available it is to our patients at this point.
And my thoughts are consistent with yours. I will say that especially as we elaborate the highest risk patients, meaning the patients with the most inflamed coronary arteries, those that already had events or multiple events, and especially if cost becomes an issue, I think it's valuable to at least explain that to the patient, but even recommend the generic medication at a lower cost, just to give them whatever weapons we may have available pharmacologically to stabilize their plaque. And to that end, last question to both of you, starting with Dapo. Where do you think, first, what's the importance of pharmacological therapies in our treatments? I mean, we always want to have some holy grail. We can give some gene therapy injection and people's arteries are clean and stuff. But where do you see some of the trends and some of the excitement going? I'll start with Dapo. What are you excited about in terms of new armamentariums or new areas, new weapons in armamentarium, or where current therapies might be enhanced?
Yeah, so I think, we've done an exceptional job of reducing cardiovascular risk over the years. Like you mentioned, with LDL lowering therapies, which we have a number of them on the market now, including PCSK9 inhibitors, small interferon RNA acting agents on the PCSK9. I think where in preventive cardiology, where we're looking now is what do we need to do to reduce that residual risk that I mentioned earlier? Someone's LDL is down to 50, we're controlling the weight, they're not smoking, their blood pressure is controlled. What can we do to prevent that person from having another heart attack or stroke? Because it still happens.
Right.
And I think
we've reduced the risk,
yeah,
but you don't eliminate the risk.
Exactly.
That's that residual component, correct?
So that residual component is where I think a lot of attention is going with these anti-inflammatory agents. In the world of cardiovascular prevention, there's a lot of attention now on reducing weight as a way to reduce inflammation. And we can talk about those drugs at a later time. But really, it's this residual risk that I think is interesting. And I think we're going to have a lot of agents in the future, whether it's targeting Lp(a), whether it's targeting triglycerides, whether it's targeting CRP. This is where the field is going.
Sergio?
I as well am really excited about what the future is going to bring in our cardiovascular field. It's a very exciting time to practice cardiovascular medicine right now for the reasons that Dapo mentioned. Of course, I believe in the future we will have more specific drugs that target inflammation being studied. Colchicine, I believe, is just the beginning, and I think as others will follow suit, it's going to be exciting to see what the pharmaceutical companies will come up with as maybe a safer, more direct target in the atherosclerotic plaque in targeting inflammation. Regarding colchicine, it's still being studied in other scenarios, in other trials right now. There's an ongoing trial studying the role of colchicine in STEMI and the role of colchicine in secondary prevention for stroke. So that would be interesting to see how that ties in those scenarios. And what's most exciting is that we're looking at patients as a whole, like Dapo mentioned, to really individualize therapies and target obesity more specifically, which is an important precursor for cardiovascular disease, and through the way that it enhances hypertension, diabetes, and sleep apnea, and it all just ties in. We're seeing the patient in a different light, connecting some dots that maybe we've known about in the past, but we just hadn't had the medicine to truly target those issues specifically. So more to come, and I'm very excited about these therapies that are coming out, and I hope that we continue using them.
Well said, guys. And again, I appreciate your ability to articulate these somewhat broad concepts. We're not going to lose sight of the lifestyle benefits, but at the same time, getting to this underlying cause of the things that we previously at a high level looked at, like blood pressure and LDL cholesterol and blood sugar, but now what's driving those things and commonalities and how we can work to them. The only thing I'd add, which is really just more of an extension of what you said, is I think we will have a much more personalized approach where we use population studies that say, well, if your LDL cholesterol is over this and you have some other things, go on a statin. And I think down the road, we'll say this statin for you at this target dose is what you need. This medication for you might be what you need. And I think that's only going to make people healthier and safer and ultimately feel better, not in just terms of decreasing outcomes, but avoiding unnecessary side effects. And actually, as pertains to the colchicine topic, the list of applications for colchicine in the multiple fields as both a therapeutic and prophylactic tool expands, and our appreciation of the anti-inflammatory properties continues to expand, as does our understanding of the mechanism of its actions. You guys have been great, and I really appreciate you bringing your expertise in this area as well as your perspective. And thanks to everyone for listening, and we look forward to having you join us again soon as we expand and explore topics in the ever-expanding understanding of the cardiac realm. And to find out more about the topics covered on the Doc to Doc podcast, please visit physiciansresources.baptisthealth.net.
To find out more about the topics covered on the Doc to Doc podcast, please visit physicianresources.baptisthealth.net.